This is a quick talk on external fixators, and I just love to put this slide up whenever I talk about mini external fixation in India, because we've forgotten the fact that a mini external fixator, Hemant and I will remember that Vinod Arora was a resident here in Nanavati, and he showed Dr. B.B. Joshi a small clamp that he had used for an external fixator in his thesis. And Dr. Joshi took that idea and ran with it and created what is known as the JESS fixator, which was then modified a little bit and came up the UMEX fixator. We tend to forget that contribution of Vinod Arora, and I always love to show that because he's been such a dear friend, unfortunately forgotten by history. So is there still a role for properly done external fixators in distal radius? I would say yes, and let me see if I can try and show you why. My first point is that if you can reduce a fracture, then a good external fixator frame can be used to hold it. Yeah, what if the fracture cannot be reduced? Would you use an external fixator then? Well, you must find a way to reduce the fracture, and then you can go ahead and fix it. So we're not talking about two-part, mildly comminuted, which are easy to treat with external fixators, and what we call ligamentotaxis can be used, etc. Let's look at some of the more challenging ones like these. Okay. So look at the voids here, look at the comminution here. This is a slide I've been showing for many, many years, but I just like it simply because it shows what is the possibility using an external fixator. So first a frame is created, pulled out to length and maintained, and then you pass in joystick wires and you bring in your fragments to where you want them to be. So you must get all the fragments back in place. Don't just leave it like the one that Hemant was showing, the last two ones that he showed. So you close down all the voids, get the entire shape of the distal radius. See that the ulnar styloid, as Rajesh was asking. But once you get this, only then would you get a healing like this and a function like this. So you must get all your components, you see all the parameters that you know how they fit into place, otherwise your fixator is going to fail. So fixator doesn't mean I just put 4 pins and I tried and held it there and I think ligamentotaxis is going to take care of everything. This is an unstable situation and you can see the deformity there. So like Hemant showed, there's an additional wire within that, and that additional wire is clamped into the frame, so it's a very stable construct, goes on to heal comparative to the opposite side, and therefore an excellent result. What about the fractures like this, where it is, like as again where Hemant said, it's not a pure dislocation, but it's a fracture dislocation as it's sometimes called. There are papers which talk about fracture dislocations and show you cases like this. But it's basically a very, very displaced fracture taking the wrist along with it. So it's and when you look for the ulnar styloid, you realize it has displaced as much as the radius has, which means the entire TFCC complex has moved down with that. Here you must put a collateral frame because you've got an injury on the ulnar side which also needs to be addressed. The most important thing that you must remember is that, well, it's not running, but the video shows that this fellow is moving his fingers. So if you can get him to move his fingers when he's in the frame and your bones are in good place, you can be assured that it is a very good result. When your patient can move his fingers fully from the fully flexed to the fully extended position, you know that the carpal height index is maintained. You know that no tendons have been impaled in your fixator. You know that the nerves are not impaled because he's not in severe pain. And you can then, if you have a good X-ray, deduce the fact that the fracture is also stable. So that's how we went on to Unite, and he's got an excellent result. So what about these? Now these are the ones that you say that always require a plate. Well, when you put to a very difficult situation, can you use it? Yes, you can. If you can reduce it and hold it down, you must know which fragment it is, and therefore your wires will either be in the volar plane or in the dorsal plane. So if you impale those wires in good position, you can get a good result. The die punch fragments, again, these are the ones that sometimes get impacted. So when we gave traction, you can see ligamentotaxis is doing nothing. The fragments are just lying impacted within. They need to be joystick back into place. Create the articular surface. Now the fragments are looking good, but look at the amount of distraction. So you must never have so much distraction. This joint space is your indicator. That's the amount of joint space that should be there between the radiocarpal joints. So you must reduce this, otherwise the carpal height index will be affected and therefore the hand will become stiff and get CRPS as we call it. So what you need to do is to reduce it. So this is where eventually we reduce the traction. You can see there's a distractor on the side. Normally we don't use distractors. Yeah, we use it to bring it down. Once that is done, the result is going to be good. So you must pay attention to all these factors, that the fragments are in place, the joints are in place, there's no over distraction, there's excellent function in the hand, you'll get a good result. Some of them are impacted like this, and whatever you do, they don't come out. So you need to do an open reduction. Once you do an open reduction and fix it down with K-wires, can you use an external fixator? Why not? So you would use an external fixator in that position, and here's a video which the patient has sent in during COVID times. So he thinks this is what I asked him, but what I told him was this. But he's got a free range of movements, as we can see. But it conveys the message. So finally, if you use an external fixator like this is a fixator I have put on many years ago, thinking यार ulnar को तो अपन anyway excision करते हैं, ये तो excision हो चुका है, let it be like this. This is what happened. So if you don't stabilize it, if you don't get it into position, you can get horrible results. Here's another one where I had pierced the wire across into the ulna and it went on to have a cross union. So you can have really bad results from external fixators if you don't pay attention to all of this. External fixators is good if used well, bad if misused, difficult post-op sometimes. Patient acceptability definitely is a problem, but you can get excellent outcomes if you take good care. So there are many of these studies and I'm not going to go through those. Yeah, except this one where it said volar locking plate versus external fixators for distal radius fractures, a meta-analysis. And after having looked at some 500 studies, they come down to 9 studies saying others didn't fit my criteria. Who are you to sit and make criteria? I don't know. But then anyway, this is how they tell you. And then you see 9 studies. So you must always remember meta-analysis means 9 studies or 12 studies. So take it with a pinch of salt. Yeah, but then read between the lines because it says dash scores are better for plating, grip extension and supination better with plates, external fixator had a higher infection rate. So it throws my talk out of the window. Then you read between the lines and it says in the first 3 months. So dash scores are better for plating in the first 3 months, afterwards they're equal. Grip and extension, supination better in the early post-op period. Again, fixators match up in the long run. External fixators had a higher infection rates, but plating had a higher reoperation rate. So it leaves you without an answer, right? So final question is, my indications for external fixation, never in volar shearing fractures and volar displaced intra-articular fractures, definitely not. Never in fractures irreducible by closed or open methods. So then I'll need something more than that. And excellent alternative when well done in patients who can't afford imported plates. We must therefore retain the art of its use because comparable outcomes are possible in special indications with patients with complex fractures on blood thinners and things like that. Patient is unfit or unwilling for open surgery, and compound situations, you must always have this as one in your armamentarium. So external fixators still has a big role in my practice, although probably I must be doing about 4 or 5 in a year. Thank you very much.